Okay, little girl.
About this thing.
Okay.
Alrighty, let's do our. We're all hooked up and go really quickly. And if you want to videotape, if we could have you hold the back leg, then we'll free up her to videotape. And you can just hold those two right there. And that frees Casey's hands up to work on the front. We're going to run an EKG during this thing for timing, but it also has diagnostic value too.
Okay.
I'm sorry, baby. That's just terrible.
I told her, I said my aid goes the same way, so it doesn't matter.
I know it. It's just hard when you're little and you don't
Oh,
understand.
yeah.
And why are we doing this? We'll just be really gentle. We're going to kind of slide her back to here. Oh, she's being so good. Look at her being good. I know it. You're cute.
And she's really good at being handled.
Oh, she's really sweet. So we're going to go as quickly as we can get our data accurately.
Okay.
Because I know she's not. Can you flip that light switch over there?
Sure.
Maybe not.
Right.
Calm down, calm down. You're okay, I know.
Alright, we're just going to kind of jump in and see if we can get our data right off the bat. Take her to the back a little bit. Back to the way. The other back.
I know.
It's okay, baby.
Hold on.
So, Cricket, it's okay.
Because I don't want to see this. I thought this would be fun. Well, the one thing that I can tell you is that it's different than what our expectations were.
Good or bad?
Well, it's not going to be, I don't think it's aortic stenosis.
Really?
No, because this is the aorta here. We can see what that looks like. But all the right side is overloaded.
No. Get yourself all worked up.
So is it like a deformed heart, maybe?
Well, we'll take a look as we easy slow down.
Slow down, honey. Cricket. Cricket. It's okay, honey. Settle down.
Wow, it's all over the place, isn't
Yeah. Well, this is left side. This is aorta, but the right side is tremendously overloaded. Volume. So let's just see what we can get here. We'll get a couple of different views and get some data. So this is she's being really good.
She's doing really good.
Yeah, she's really sweet. Try not to rock the boat.
She
on her.
loves to be talked to. I'm right here, Cricket. Now, when you say it's to the right side, is that a concern of ARVC? I know ARVC is electrical, so I don't know if you could see that.
It is, and we
Yeah.
don't normally see. The Holter is much more sensitive for electrical, disease and mechanical disease.
Sure.
The Echo would be the tool of choice for for like the diseases, structural diseases like SAS and things
Sure.
like that. See, that's a pretty normal pulmonic. This is a pulmonary artery velocity, and that looks pretty normal.
For the left side?
Right side.
Oh, that's the right side?
Yeah.
Because I remember you said the right side sounded normal.
Yeah. Well, it radiates to the right side.
Okay.
She is being so good.
She's a
There
good
seems to be almost a misplacement to the tricuspid, bicuspid, no, I mean, I'm sorry, the tricuspid valve there on the right side of the heart.
Now, is that a deformity or?
Well, it could be. We're going to see if we can get just a little more information about it. Let's see where that is in this view.
Are you farting on me? I think she is.
So now we have a tremendously large, excuse me, a right atrium, in which looks to be, again, we're going to look for the placement of the valve. The tricuspid valve is the valve that regulates inflow from the right atrium to the right ventricle. Let's put it, see if there's dysplasia of this valve.
Can I turn a light for Ashley here, Joe?
Yeah.
Oh, thanks.
I'm going to come from underneath and see if you can get the aortic velocity.
He's such a good girl, Cricket. Isn't she awesome?
She's
Cheers.
Oh my
Even
god.
a little bit is good.
She's such a good girl. Such a good girl.
So here's your transaortic velocity. So this is a velocity coming out of the aorta. And this is a subcostal approach. Let's
And what
start
does that mean?
over. This would be the gold standard for subaortic stenosis. This trackball sticking. So there's your aortic velocity. Right there, your peak velocity, AVP, is 174, so that's not aortic or subaortic stenosis. The velocity is not elevated, which it is in that disease. So we're shooting right up the aorta here, right out the aortic outflow tract, putting our Doppler signal right there, and we'll measure it again for verification.
It's real even, isn't it?
Yeah, it's beautiful. So that is, again, a 1.71 velocity. So it's not aortic disease.
Because your flow for boxers are 2 point. Is that the flow? 'Cause-
Yeah.
So 2.5 would be, where's our cutoff for our boxers?
2
so
to 2.5.
So 1.7 actually is really good
It
for a
is,
flow.
it's really good. So, I mean, you don't have subaortic aortic stenosis. Not
Wow.
with a velocity of 174.
No.
But what you do have is you've got right side heart disease. So we can have a couple of different forms of right side heart disease that can do this. And it's key, you could have tricuspid dysplasia, but we want to make sure that it isn't, there's an anomaly called Ebstein's anomaly, which can, it's an atrialization of the right ventricle that can be very, very consequential and life-limiting.
Wow.
So we're going to take a look and check a few different things. We'll look for pulmonic disease right here. Again, that's the pulmonic flow there. That's all pretty normal. We're going to go out here and just make sure there isn't a peripheral shunt like a PDA. She went to sleep. Says you guys are boring me to death. This is really dull.
She's such a sweetheart. I deal with her I work with her so much at home. 'Cause I try to keep her calm. I take her out anytime she's panting or she seems real restless. I always take her out and calm her down before I put her back in her crate to get her heart rate down. So she's very used to being held in a place, you know. She's being so good.
Oh, she's an angel.
I love her.
All right, well, this is not your common everyday boxer form of heart disease in any sense. So that's all fairly normal too.
In a way it's good, in a way it's bad, because it's kind of hard to figure out what the problem is.
Well, I'm
but-
going to go back and now, again, the most significant finding is this really, really overloaded right atrium.
Is that white fibrous that I'm looking at?
This is this whole chamber here.
That whole chamber
This
there?
is a normal left atrium.
Okay.
This is the left ventricle here, and you can see the mitral valve opening and closing here. Now up here you can see the tricuspid valve in between a very, very large and dilated right atrium.
Oh, so that whole thing is
This
a right?
whole thing. And
Holy
these should
cow.
be equal size.
And it's twice the size.
Right, probably 5 times the size. This
Oh
is
my
the size
God.
of this chamber. This is the left atrium. This is the right atrium.
Oh my goodness.
And it
See, I didn't
is-
realize that was the whole heart
Yeah,
there.
that's all the heart. So if I go up here,
Wow.
you can actually see the vena cava, and we can get blood flow coming in
Oh
from
my
the vena
goodness.
cava. Right
So we're
there.
probably lucky she even survived this long yet,
Well,
huh?
let's take a look and see what we've got. I mean, I want to
Oh
see
my
if it's
God.
if it's tricuspid dysplasia. It would certainly explain a lot.
Yeah.
But with tricuspid dysplasia, we can get that Ebstein's anomaly, which is it's a very, very consequential change. And most dogs with it don't survive much longer than 5 months. But if it is not an Ebstein's anomaly, then she'll probably live to be an old lady. Let's get ready to flip her. Because dysplasia doesn't always have to be consequential.
Okay.
The Ebstein's anomaly, absolutely.
Okay.
So,
Being such a good girl.
hold on, sweetie, look towards us. Look her this way.
You're all right.
Swing her around.
Oh, okay.
How about if I get back there?
Her leg's caught. Her leg's caught underneath there.
Oh, here.
Yeah.
Oh,
There you go. Her leg's caught. There we go. It's okay, honey. It's okay, honey. It's all right,
They
sweetheart.
don't normally.
It's okay.
I've worn them.
Being
I
so
wouldn't put them through
good.
something I hadn't done myself. They don't really hurt. They're not the most comfortable.
You're okay.
thing.
You're okay, honey. I'm right here. Mama's right here, honey. You're being such a good girl. Yes, you
Tummy back
are.
down again.
You're being so good. Yeah.
Now mom can talk to you.
Yes.
All right, let's see what this looks like. This will kind of tell us.
Mama's
a lot.
here. You'll be all right.
Girl.
So there is, again, our absolutely huge right
Wow.
atrium. This is a left atrium again by comparison. That's the aorta. So let's see. There should be a massive leak on this valve, and we should get a hissing spray sound. And there is just an enormous leak. You'll hear it. Hear it? The hiss?
Yeah. Yeah.
So that is that's your tricuspid regurg.
So is that what's bad?
Well, we do have some potential pressure issues with maybe a little bit of hypertension on that side as a result. It does tell us that you have a massive leak on the tricuspid valve.
Now, what causes that, doctor?
It is going to be I'm not sure in your breed if it's going to be considered as much genetic as it is developmental.
Okay.
Sometimes it's really hard to tell. Now, if it were a retriever breed, we would be calling it.
I don't even know if that it'd probably be of being in our breed for that. So, I know we got enough heart diseases.
Yeah, but in your breed,
Ugh,
we just don't normally see it. I'll
right.
have to look it up and see. And we might want to get you a genetic consultation.
Okay.
And there's Kate Mears is an excellent.
Yeah, I know
Gen-
Kate Mears.
Yeah, it's also a geneticist. We might make a copy of this study and send it off to her.
Okay. And she knows me too. I've talked to her
Okay.
several times on the phone. And met her, and of course she comes to our nationals too every year.
Yeah.
Now, is this something that can be corrected with surgery?
Not that I know of. And again, look at the massive lesion there. And the most telling thing is the second, you can just hear it.
Wow.
That's your murmur. That's what we're hearing with the stethoscope, incidentally. That massive sound.
My heart's just broken.
I know. Well, let's see. I mean, if it is tricuspid dysplasia in the absence of anything else, then it isn't quite as consequential. But if it's got the Ebstein's anomaly with it, it can be disastrous. I'm going to come at it from a slightly different view. And I'm recording this study as well.
Okay.
Different facets to the study. So I'll make you a CD,
Okay.
and
Thank
you can
you.
send it off for analysis. Here's the tricuspid valve. See, right now we're trying to pair up the valves.
Uh-huh.
We're trying to see what is the alignment and placement of the valves. Because that's one of the biggest criteria that we use to trying to decide. And it's a very subjective assessment, whether they have that particular anomaly.
Uh-huh.
And it's a very rare anomaly. You can see the abnormal blood flow. Now, by comparison, look at the uniform blood flow here,
Uh-huh.
all red, perfect uniform color, okay? That's very laminar flow, right? Very
Okay.
uniform.
Uh-huh.
When I get over here to the dysfunctional valve,
It's all over the place.
look at the colors.
Wow.
Right? That tells you there's pathology on that valve.
It's just leakage everywhere.
Yeah, because this is turbulence. This is abnormal flow. And that is characteristic of some type of a valvular disease. Send it to Kate, see what she says. It's my opinion. I don't think she has the anomaly.
Okay.
And it's a very subjective opinion.
An anomaly, is that in her favor or
That's in her
against?
favor.
So what do we do with her?
Well, good question. A lot of these patients live a normal life. She doesn't have a surgically correctable disease. Let
Okay.
me
You're being so good, baby girl.
let's get some other opinions.
Okay.
Let me post the data out
Okay.
and see what everybody chimes in with it. Yeah,
Okay.
we're on a listserv of universities and cardiology departments and cardiologists and stuff. I've got some pretty good images.
Yeah, it looks like you did.
Let's send them out and see what
Okay.
everybody thinks, and we'll
Okay.
get more than one opinion.
Oh, I appreciate that.
Yeah,
Dr.
my
Randall.
opinion, and we'll get some treatment advice as well to see if they think that the severity of the lesion is warrants treatment. If she doesn't have Ebstein's anomaly, which is a misplacement of the valves, if it's just a dysfunctional valve or a dysplastic valve, it's just like hip dysplasia. Something didn't form right and the hips are a mess.
Sure.
Something didn't form right in this valve. Do you have that 4-chamber heart model diagram? Is it over there?
You're being so good.
There, I don't have it here. Let's see if we can find it because it's easier. Up at the cardiology department of Wisconsin, and they were presenting new ideas and techniques for procedures that they were doing, and as far as I know, there isn't anything here. This is the dog's heart. They have 4 chambers the same way we do. They have 2 atrium here and here, 2 ventricles here and here. These are the peaker pumps. They pump and load the main pump, and the main pump ejects the blood out.
Okay.
And the blood comes back from the body with no oxygen, gets pumped into the right ventricle, out to the lungs. This is a lousy pen. Can you grab me another pen case, please? And it picks up oxygen in the lungs, comes back to the left side of the heart, pumps it from the left atrium into the left ventricle and out to the body to deliver that oxygen.
Okay.
Let's try that one. Thank you. Does that make sense?
Yeah.
Kind of a double circulation pump. 1 to and from the lungs, 1 to and from.
One goes in, one goes out.
Yep, it's
Yep.
exactly true. And now they have 4 chambers, 2 main pump chambers and 2 primer pump chambers, and each chamber has a valve.
I've been very much into understanding the whole, because I've been in the breed for over
Good,
20
yeah.
years.
You know
and
heart disease then. You
Yeah.
know what happened.
yeah,
Now,
and I lost one at 6.
Yeah.
She had both. She had ARVC and
Okay.
SAS.
And, okay.
she had both.
And you can have multiple forms of disease, and we see like ARVC and DCM in boxers, where the mechanical disease or the electrical disease, eventually becomes mechanical disease,
Right.
and they end up in heart failure or something like that. ARVC is an electrical conduction disease, where there is abnormal electrical activity in the heart that produces abnormal and ectopic beats, or VPCs, ventricular premature contractions, or ventricular ectopic beats. Okay, SAS is an outflow disease.
Right.
All right, inflow valve, outflow valve, right here, mitral valve, there, aortic valve, here. Subaortic stenosis is a restriction right here.
The thickening of the.
It's a thickening right here, and now you pinch the hose on a garden hose, and if you put your thumb over the end of the hose and you make the opening smaller, the velocity shoots out. Instead of coming out in a dribble, it goes fast velocity and goes a long distance, right?
Right.
And that's what you hear as a heart murmur. You can hear that if you
Okay.
pinch the hose and listen to it, you can hear of the.
They must teach you guys that in school, because everybody that's ever explained this to me says the exact same thing about the hose.
It is. They do. Yeah, it's a common
Yeah,
analogy.
it's a great
it
way to
does
think,
work.
because you can understand that.
It does work. So what we have to see with a restrictive disease is a high velocity. So this is why the AO velocity is the gold standard for SAS. If you have no increase in aortic velocity, it's hard to say that that patient has SAS. And he is at 1.74.
Wow.
And your velocity is a very
That's really
normal
good, actually.
velocity. It is.
You walk out there singing, and when they're 2 years old,
Exactly.
that's
perfect
a beautiful
velocity.
flow.
If that were a mature 2-year-old
Yeah.
velocity, you'd be doing handsprings.
Exactly.
Right side. All right, right side is a pulmonary side. This is the aortic side, sends blood out to the body. Remember, this one is a send out to the lung side. So you have an outflow valve and an inflow valve. Okay, if you have stenosis here, it's called pulmonic stenosis. Okay, you don't see subpulmonic stenosis, but you see pulmonic disease and stenosis, and you can have regurgitation. That's your outflow disease for this site. Your inflow disease is tricuspid dysplasia. Okay, so this is a dysplastic valve, okay? And so it's really kind of flapping in the breeze.
Is that what she's had? Is that what she has? Okay.
For sure. She
Okay.
has tricuspid dysplasia.
Okay.
The valve is just not working, and you can see that every time the heart contracts, it's going to plunge blood out the outflow, and it's going to close the inflow valve, right? So the
Wow.
blood doesn't go backwards, it only goes forward. So during contraction, the outflow valve opens and the inflow valve closes. When the heart relaxes, the outflow valve closes, so we don't get blood coming back.
Regurgitation?
Regurgitation, and then the inflow valve opens to allow more blood to fill for the next cycle.
Okay.
Does that make sense?
Yeah, very
Okay,
much
so
so.
this valve is flapping in the breeze. It's not doing anything in Crickett, and
Wow.
it's just completely dysplastic. So it's like two swinging doors that don't even come close to
So stuff's
meeting.
just flowing in, but it's not giving it time to refill. It's
Right.
just
So
yes.
every
Okay.
time the heart beats, we get a huge ejection wave going backwards, and it's causing this chamber to be enormous.
Is that flapping I see?
Yeah, yeah. It's just not.
It's like a
working.
deflated balloon,
Correct.
sort of. Okay.
Exactly. And so it's overfilling this. The first thing that we noticed was is a normal sized left atrium and an overloaded right atrium, because it's just all this blood is going backwards, and it's creating a backlog of blood because less of it is going.
So is that
forward.
what caused her to pass out then?
Probably.
Yeah.
She's having
Overwork.
disease. Exactly. She's probably getting.
I don't let her play more than
under-oxygenated.
5 minutes,
Yeah.
and then I pick her up, calm her down, and then
And
put her in a
it
crate.
Takes care of it.
Yeah.
So the Ebstein's anomaly
Which is why I
then
can't let her play hard.
is an addition to tricuspid dysplasia, and I'll write it all down. You can
Okay.
research it.
Thank you.
In addition to tricuspid dysplasia, you've got a misplacement of the valve. So the valves are down here, like this, and we have a displaced valve like that. And so this anomaly produces an enormous right atrium, but now we have a very small capacity for the right ventricle, and instead of being able to handle the extra workload, it cannot.
Because it's not working
It's not
appropriately.
working well.
Correct.
Its volume is reduced, and that is Ebstein's.
You're
And
not seeing that in her?
it's a subjective call,
Oh.
and it's a hard call to make. You have to really, really look at several different parameters. I don't think so. That's the best answer I could give you. We'll put it out on the listserv and see if anybody
Okay.
else thinks so.
Okay.
But I don't think so. If it does, unfortunately, this puppy won't live to past 5 or 6 months. They never do. And
That's if she has the Epstein or if she
Yes.
doesn't.
if she has
If she
Ebstein's
has it.
anomaly as well, that's a double whammy.
That means that
It's more than she can withstand.
if she
but
doesn't have Epstein, she
should-
could live to be old.
With or without medications.
Okay.
Some of them don't even need to have medication, but she's symptomatic. She may have to have medications.
And what would you think she has
Well,
Epstein or no?
No, I don't think so.
Oh, well,
But
that's
it's a
good.
very subjective call, and you can have it. And it's not an all or none call either.
Okay,
it's
that's
a
good.
variation. It's not like being pregnant where you're all or none pregnant. She could have mild Ebstein's anomaly. She could have severe Ebstein's anomaly when the valve is down here.
Because it's
instead of
working
up here.
sometimes, it's just not
Yeah.
working efficiently.
Correct. So I mean, it's not an always or none thing, and
And it's not something that will get better as she gets older, right? Because the
not
heart is
that.
what it is, right?
Not
Okay.
that. She won't survive it. She won't survive it, unfortunately. I have only seen one Ebstein's anomaly in 20 years of doing this.
Oh, my gosh.
It is that rare, and I see patients like this all the time.
Okay.
And I've seen it once, and it was very
Wow.
obvious the time I saw it.
Okay.
So I called and I told the people, I said this dog was not going to survive, and it did not. So I would say it doesn't look like it.
Okay.
But it's not an all
gives
or
us some
none.
hope
It
then.
does, it does. And if honestly, if it's not an Ebstein's patient, you're gonna know by 6 or 8 months because if
She won't
if she's
live.
alive at her first birthday, she'll probably live to be a ripe old age.
Oh, that's
So and
That's good.
they oftentimes can compensate as long as there's a healthy ventricle. They can compensate for that.
now. Is it something that throughout her life we should restrict her exercise?
Good question.
'Cause I do that
Normally
now.
we don't. Normally they don't. Let me pull a reference and see what
Okay.
the reference.